Okay, we can get started. Welcome everybody to the Musella Foundation's Brain Tumor Awareness webinar series. Today's topic is the current status and future directions of focused ultrasound for brain tumors. Our special guest speaker is Dr. Suzanne LeBlang. She's a neuroradiologist and the Director of Clinical Relationships at the Focused Ultrasound Foundation. Thank you for having us. Go ahead.
Hi, everybody, and thank you, Dr. Musella and the Musella Foundation for allowing me to speak, especially on Mother's Day when this is what I love to talk about and I'm passionate about it. And thank you all for making the time to be with us today. So focused ultrasound has the potential to enhance the effectiveness of or provide an alternative to 4 current pillars of traditional cancer treatment. So for example, with surgery, perhaps focused ultrasound can replace invasive surgery by ablating tissue, heating it up until it just causes the tissue to die. It can enhance radiation sensitization. It can help do targeted drug delivery for chemotherapy and can also enhance immunotherapy. So there are 2 current problems if we want to categorize them with our treatment of brain tumors. Number 1, we really don't understand the tumor biology. The WHO classification system for brain tumors now includes not only the histopathology, the classic way of diagnosing it, but molecular signatures. And the reason this is important is that even within a glioblastoma, as you can see here, the different colors represent different cell types at different stages of differentiation. And each of these cell types that's in the glioblastoma could potentially only respond to a specific type of therapy. So we need to understand the cellular makeup of it, the genetic and epigenetic signatures of them. And once we understand them, we can then develop actionable therapies for these mutations. So that's one problem. We got to understand tumor biology. Second problem is we've got this blood-brain barrier, okay? So as you know, the blood-brain barrier prevents bad stuff from getting into our brain, which is good for us, but it also prevents good stuff from getting in there, like chemotherapy and agents, other neurotherapeutic agents. So focused ultrasound is a non-invasive way to provide targeted drug delivery across the blood-brain barrier, and we're going to talk about that. So an interesting analogy I heard recently is perhaps when we give a chemotherapy agent or an immunotherapy agent, and we give it intravenously or oral, it goes everywhere in the brain, and we try to get it past the blood-brain barrier. But it's like trying to get oil in your car. If you just pour the oil all over the engine, some of it will go where you need it. But if you use a funnel and a directed pour of the oil to exactly where you need it, then it's obviously much better. So I want you to remember this analogy and remember the shape of the funnel, okay? So let's do problem number 1, tumor biology. How are we currently finding out what's inside the tumor? Well, we can look at it under MRI scans, and we can see the anatomy of the tumor where you've got this enhancing component where you do have some blood-brain barrier disruption. But there's also a part of the tumor called non-enhancing tumor. And it's the part that's non-enhancing on the post-contrast images, but it's hyper intense on flare sequences going across the corpus callosum and into the thalamus. And we know that these areas, as well as other areas around the enhancing portion, are responsible for the recurrences. So there's infiltrative tumor there that's seeding the brain, but it's not opening the blood-brain barrier yet. Another way we have it looking where the tumor is with nuclear medicine scans, and we can even look at tumor metabolism in certain amino acids. So in this particular nuclear medicine scan, we can see on the MRI scan the enhancing tumor, but the area of increased metabolism, the active parts of the tumor, are actually in a much larger area than just what we're seeing on the anatomic images. So why is this important? Well, we kind of use this to guide maximum safe resection at surgery. They're also using certain agents, contrast agents and fluorescein to highlight the tumor so the surgeons can resect as much as possible. So obviously surgery is invasive. It is targeted with the use of MRI, nuclear medicine scans, and the contrast agents. But obviously these invasive surgeries come with a risk of bleeding, infection, and other things. Radiation therapy also uses these images to confine radiation therapy. So it's good, it's non-invasive. It is somewhat targeted. We may not see some of these infiltrative areas, but there's side effects like radiation necrosis and off-target effects. So that's one problem. Second problem, blood-brain barrier. So when we give oral or IV chemotherapy agents or immunotherapy agents, it's non-invasive, it's just an IV, but it's non-targeted. It's like that oil going all over the engine. And as we know, a lot of materials do not cross the blood-brain barrier. And because they don't cross the blood-brain barrier, they're not efficacious, and it results in a lot of systemic toxicity. So in this diagram, it's showing how if you can open the blood-brain barrier in the area of the tumor, you can get molecules to cross in a targeted fashion into the area of the tumor. There are also invasive ways to directly inject chemotherapy agents or immunotherapy agents, but they use catheters, convection-enhanced delivery, wafers, but again, those are invasive. So we're back to the blood-brain barrier. How can we non-invasively and in a targeted fashion open it to let things through? So in this diagram, these are the endothelial cells, and these blue things in between the endothelial cells are tight junctions which hold the cells very close together. So it's normally good for us because things like bad viruses and toxins don't get into our brain. But also if we want to get antibodies or other neurotherapeutics or vectors, viral vectors that carry specific helpful therapeutics can't get through. So you can see here in a normal fashion, those tight junctions in blue don't let things cross. So how can focused ultrasound help? Well, let me tell you what focused ultrasound is. First, consider diagnostic ultrasound. Like when you get your gallbladder scanned, or if you're pregnant, you get an ultrasound probe and it fans out the ultrasound beam to create a picture. That's great. But focused ultrasound is the reverse. You take a transducer and instead of fanning the beams out to create an image, you make the beams converge at a focal spot, focused ultrasound. And at that focal spot, a lot of very interesting things can happen. It's analogous to the sun's rays outside when you take a magnifying glass and you make all the beams converge at a focal spot, like at that leaf, and you can generate fire and heat. But if you put your finger in the middle over here, nothing will happen to it. The energy is only at the focal spot. So immediately I want you to start thinking how this focused ultrasound beam can help fight brain tumors. So it turns out there are multiple ways that the focused ultrasound beam can be used in this targeted fashion. Okay, so you can break it up into two types of mechanisms of action: thermal mechanisms of action and mechanical. Again, we can adjust that beam by adjusting the power and other settings to create thermal energy or mechanical energy. And there are subsequent bioeffects. So I'm going to talk to you about this for a little bit. So one of the areas that is best known is how we can use the beam for thermal ablation. So I'm going to show you this picture, this video. So this is a focused ultrasound machine. So the patient's inside an MRI machine so we can see the anatomy. The ultrasound transducers around the patient's head. And we're going to make all those beams converge at a focal spot, just like the sun's rays on the leaf. And at that spot that we can see with the MRI scan, we can do amazing, amazing things. One of them is thermal ablation. Just like we generated the fire on the leaf, we can generate temperatures as high as 60 degrees Celsius, which is like 160 degrees Fahrenheit, and make all the tissue in that region die. So one of the already approved FDA indications to ablate tissue inside the brain is for essential tremor. So here we have a patient that has a very bad tremor. He's an architect and he was unable to perform activities of daily living, as you see here, as well as his profession. When he tried to draw inside the lines of the snail diagram or these lines, he obviously could not. We did focused ultrasound on him and we made all those beams converge at a focal spot right here where the tracks that are causing those tremors occur. And then after the procedure, you can see here that the tremor is gone. He can perform activities of daily living. His snail diagram is clear. And the way we do this inside the MRI machine is we use the MRI scan to show us exactly where we want to hit anatomically. And then the MRI scan can generate these thermal images with a graph of the temperature. We want to make sure we reach a certain amount of heat that shows us that the tissue is killed. So again, I want you to start thinking how we can use this beam for brain tumors and glioblastomas. The Focused Ultrasound Foundation is dedicated to exploring the neurological landscape and the use of focused ultrasound. And we call this a rainbow chart, and it shows how ideas go from concept to preclinical studies through pilot and pivotal trials, all the way to outside and US approvals, FDA approvals, and US reimbursement. As you can see here, astrocytomas and glioblastomas are at pilot trial stages and have just started going on to pivotal trial stages. So we'll talk about that. And now we're going to go back to this mechanism of action and bioeffect chart. I want you to keep in mind these little color-coded circles here because it's going to help us follow along the course of the lecture. Here are those 5 different main mechanisms of action. And this is specifically from our State of the Field report to show how these 5 mechanisms of action apply to the field of oncology. So the green circles are mechanisms that are being used at preclinical investigations, the yellow ones that are in clinical trials, and the red one is regulatory approval, and that's the thermal ablation I just showed you, okay? So that's all the ways we have it trying to affect oncology. If we wanted to get more specific, I pulled this page from the State of the Field report that talks about the 5 mechanisms of action and the different types of tumors. So what I hope you'll notice here is that for glioblastoma, there's a tremendous amount of research into all of these mechanisms of action and how it can affect the treatment of tumors, from mechanical ablation with histotripsy, thermal ablation and thermal mechanisms with hyperthermia, some blood-brain barrier opening. So we're going to talk about this. But again, it shows you how much research and trials are going on with glioblastomas and these 5 mechanisms of action. So let's talk about blood-brain barrier opening and drug delivery first. There are hundreds of articles published about blood-brain barrier opening and drug delivery for glioblastomas and other disorders. So again, in the part of the brain where you don't do focused ultrasound, our blood-brain barrier is intact and most therapies cannot cross into the brain. However, when you do focused ultrasound in this area, you can open these tight junctions, and then the therapies that are inside the blood vessels can start to seep out into the brain, as shown in these videos. Here it stays in the circulation, and here it comes out of the circulation. So back in 2018, there was the first report about blood-brain barrier opening in primary brain tumors with MR-guided focused ultrasound. And what this picture here shows is a small area of contrast enhancement where we opened the blood-brain barrier in the area surrounding the tumor. So this was so exciting that we could not only use the machine to safely open it, but we could see the contrast enhancement confirming that the blood-brain barrier was open. And this picture down here, here's someone at baseline, T1 image with gadolinium, you don't see any contrast enhancement, but after the gadolinium, you can see the contrast enhancement around the tumor. And again, start thinking when we open the blood-brain barrier there, we can get drugs into this infiltrative region. After 1 day, there is no more enhancement. The blood-brain barrier safely closes. In 2020, there's been a report of 6 patients that had 145 blood-brain barrier opening sessions. As they gave the chemotherapy during their maintenance chemo, they kept on opening the blood-brain barrier. And it showed in these patients that had repeated blood-brain barrier opening, it was accurate, safe, and reversible. There's even 1-year follow-up data in a subset of patients. So the question is, how much drug crosses the blood-brain barrier? Well, without focused ultrasound, and these are very general numbers, but I just tried to kind of summarize the literature, about 20% of some drugs, 20% plasma level of some drugs cross the blood-brain barrier. Perhaps with radiation therapy, it increases to 35%. With focused ultrasound, there have been reports that get 5 times the amount of drug delivery into the tumor compared to the plasma, 30 times the amount of antibodies, and some reports 7.7 times the amount of drug delivered to the tumor compared to the plasma without focused ultrasound. So we have proven in numerous studies that drugs do cross the blood-brain barrier. And then the question is, if the drugs cross, do they work once it crosses? So let's talk a little bit about all these things. Currently, right now, there are over 287 patients in 14 clinical trials, each of which will have multiple blood-brain barrier opening sessions to deliver a variety of neurotherapeutics, from chemotherapy agents to immunotherapy agents at different stages of disease. So let me show you a few examples. Here's a patient with a glioblastoma presentation. You see the necrotic center with the contrast enhancing rim, a tremendous amount of edema, and we know that there's infiltrative tumor in these regions that are not enhancing, mass effect with compression of the lateral ventricular system. After surgery, we see the postoperative bed, marked improvement, a little bit of enhancement surrounding the postoperative bed. We open the blood-brain barriers so you can see the increased contrast enhancement surrounding the tumor bed. They're going to get the chemotherapy agent in this case. After 6 months, we see marked improvement, and at 12 months, no residual sign of tumor. That was for a primary brain tumor. There's another study going on, and these images are courtesy of Dr. Lipsman from Sunnybrook Hospital in Toronto. They're doing targeted drug delivery for metastatic breast cancer, for HER2-positive breast cancer. And they did something very interesting in this study. They labeled the Herceptin so that we could see it on the nuclear images. So let's say in this picture, we can see the enhancing metastasis. Here it is before focused ultrasound opening of the blood-brain barrier and after. And this is the labeled Herceptin. So you could see how much more labeled Herceptin got into the metastatic focus after blood-brain barrier opening. Very exciting work. This case is courtesy of Dr. Graham Woodworth. And they're showing the area that they're going to open the blood-brain barrier around the tumor margin. This is before blood-brain barrier opening, a little bit of enhancement, but we know we want to get this area around it where there's infiltrative tumor. After blood-brain barrier opening, you can see the enhancement in the area that corresponds nicely to the area that opened up. And what Dr. Woodworth and others are doing are correlating the acoustic emissions of the harmonic dose maps from the focused ultrasound blood-brain barrier opening with the amount of contrast enhancement. So it's not like an on or off switch. It's actually like a dimmer switch. We can open the blood-brain barrier more for larger therapeutics and just open it up a little bit for smaller neurotherapeutics. So currently there are a few manufacturers in this space to help open the blood-brain barrier. I showed you the MR-guided platform, which is Exablate by Incytec. There's another company called Navifus, which is a neuro-navigated system. So you take an MRI scan that was performed at a separate time point, and while the patient is in the clinic, you use the MRI scan with optical guidance to place the transducer over the correct position to target it into the area you want. And there's another manufacturer called Carthera, and they actually implant the transducer in the skull overlying the postoperative bed. So no imaging guidance is necessary because it's already in the correct position. So this slide, I want to show you that we know that this is probably working. So in one of Carthera's clinical trials, they gave monthly sonications and delivered carboplatin. And they looked at blood-brain barrier opening. So here, pre-focused ultrasound in the postoperative bed, there's no enhancement. After blood-brain barrier opening with the Carthera device, you can see the blood-brain barrier opening. The median progression-free survival and overall survival was improved in the patients that had the blood-brain barrier disruption compared to those that didn't have the blood-brain barrier disruption. So we know the blood-brain barrier is opening, the drug is getting in, and it's resulting in improved clinical outcome. How else can focused ultrasound help? Well, we just talked about the targeted drug delivery and blood-brain barrier opening. Well, it turns out that glioblastomas are what we call a cold tumor. It doesn't allow our own immune system to come in and help fight it, which we want it to do. We want our body to help fight diseases and tumors. So glioblastomas are what we call a cold tumor. It's not inflamed. A partially inflamed tumor is able to recruit T cells and NK cells around it, but that's not even good enough because it's not getting inside the tumor to be able to kill it. We want an inflamed tumor where those T cells and NK cells and other immune fighting substances can get inside the tumor to help kill it. So we want to change a cold tumor to a hot tumor. So how do we do that? Well, in this diagram here, there are multiple ways to change a cold tumor to a hot tumor. Radiation therapy has been shown to do it, targeted therapies, cytokines, vaccines, CAR T cells, chemotherapies, oncolytic viral therapies. So I'm sure you're already starting to think how focused ultrasound can help enhance the delivery of these therapeutics to help convert a cold tumor to a hot tumor and allow improved treatment. And this brings up the concept of the cancer immunity cycle. So how does our body help fight tumors? Well, it starts with stage 1, where tumor cells release antigens. And I'll give you a little spoiler right now. In order to release these antigens, there are multiple modes of focused ultrasound that can release the antigens, which will then allow the antigen presenting cells to pick up the antigens, bring it to the lymph nodes, help traffic T cells into the tumor. So we can do that with increasing cytokine expression and adhesion molecules. We're going to get those T cells to go into the tumor, brain barrier opening, drug delivery, and then we're going to get those T cells to recognize the cancer cells and secrete those substances to kill it. So the blue arrows around here are ways that we've shown that focused ultrasound can help this cancer immunity cycle. Well, remember how to change a cold tumor to a hot tumor? One of them is to get cytokines in there. So in this preclinical study, they used focused ultrasound and blood-brain barrier opening to enhance IL-12 delivery to brain tumors. And what they showed was that the combination of IL-12 and focused ultrasound resulted in improved survival compared to either IL-12 alone or just focused ultrasound. It also improved the regulation of the CD8 T cells compared to Treg cells. And again, it was the combination of the two that was important. How about for gene therapies? So we could put genes and other substances in various types of nanoparticles. And here are some substances that we want to try to get across that blood-brain barrier, from small molecules to antibodies, viruses, and then we're getting larger and larger and larger until we actually want to put NK cells and other cells across the blood-brain barrier, which are larger. But in this particular study, what they showed was that if you put these gene therapies inside a nanoparticle and deliver them just in the region of the tumor with focused ultrasound, you can enhance the delivery to the area of the brain that you want and limit the systemic toxicity to other organs like the kidney, lung, and heart. Very exciting. What else can we deliver to make a cold tumor a hot tumor? How about some of those NK cells? So in this study, they delivered NK92 cells with focused ultrasound. And importantly, they showed that the combination of focused ultrasound plus the NK cells improved their survival versus either one alone. How about CAR T cells? I hope you guys have heard about CAR T cells. It's a very exciting area of research for cancer therapy. And here's a nice review article about talking about immunotherapy and adoptive cell therapies. And these CAR T cells are very specific because they can really attach itself to the cancer and help kill it. And interestingly, the 4th generation of CAR T cells is now developed. And guess what it has attached to it? Cytokines. Because remember, those cytokines help convert it from a cold tumor to a hot tumor. So you're inflaming it, and then you're giving the cells it needs to help fight it. So this is great. So those T cells, those CAR T cells, we want to help them cross the blood-brain barrier. So I told you before that we can open the blood-brain barrier, those tight junctions, and get those T cells through. Some studies have also shown that focused ultrasound increases the production of cellular adhesion molecules along the endothelium. So these cellular adhesion molecules help attract the T cells to attach the endothelium so they cross more easily. So Dr. Sabag in his lab is doing some very interesting work on blood-brain barrier opening with focused ultrasound to enhance CAR T cell therapies. And he explored it with EGFR mutations and again showed that the EGFR CAR T cells with focused ultrasound sonication resulted in improved survival than those cases without the focused ultrasound added to the therapy. Okay, so that was blood-brain barrier opening and drug delivery and a little bit of immunotherapy in there. Let's talk about hyperthermia. So, let's say we have a drug. These yellow things here are drugs inside a liposome, okay? And let's say we inject that in the patient's IV bag, but we only want to get those liposomes to go to an area of tumor and release the drug there. Okay, so you've got yellow drug inside a blue nanoparticle. If you take a tumor, if you take a tumor and do focused ultrasound only in the tumor, those blue liposomes are going to release the drug just in the tumor and help it work and decrease the amount of drug where there's no tumor and avoid systemic toxicity. So these are temperature sensitive liposomes and you just need a little bit of temperature elevation to release them from those liposomes, and that's what focused ultrasound can do. Another interesting area of research was with this publication that just came out with focused ultrasound hyperthermia augmenting the release of glioma-derived extracellular vesicles with immunomodulatory capacity. Now, extracellular vesicles are very interesting substances that are released from cancer cells, and they help cancer cells communicate with each other. So they contain super important information, okay? And these can help the cancer immunity cycle at multiple levels by helping to recruit T cells and helping to augment this immune response. So in this study, they showed that mild fuss hyperthermia, if you increase it to about 41, 42 degrees Celsius, you can get a 46% increase in the extracellular vesicles released. And in those extracellular vesicles, you actually see a shift in the proteomic profiles with a decrease, a decrease in the cancer progression markers. So there's downregulation of the substances that usually promote tumor growth, and upregulation of the ones that help us fight cancer by increasing inflammation and getting those cold tumors to become hot tumors. So this is a very interesting area of research with hyperthermia. So the Focused Ultrasound Foundation is very dedicated to immuno-oncology. We really think this is a super important way of attacking cancer. So we had a cancer immunotherapy workshop in 2019, and out of that came a white paper, which is available on our website. And we also published some guidelines for reporting and how to do preclinical and clinical work with immunotherapy assays and substances. So it's all on our website. Okay, what else can we do to help fight glioblastoma? Well, we can use focused ultrasound in a mechanical / thermal fashion to do things like sonodynamic therapy and radiosensitization. Okay, so let's talk a little bit about this. It turns out there were some very seminal preclinical papers that talked about sonodynamic therapies for malignant glioma. So what's sonodynamic therapy? Well, it turns out if you give a substance like 5-ALA or fluorescein and you activate it with either light or ultrasound, you convert a substance to produce reactive oxygen species, free radicals. And in that area where you're converting the substance into these free radicals, it kills the tumor cells right there. So it's very targeted. Wherever you have the drug and you activate it, it will kill cells, okay? It turns out that 5-ALA accumulates in glioblastomas, and they can actually use it along with another substance like fluorescein to help in surgery for those maximum safe resections, right? So we know the 5-ALA accumulates in the glioblastoma. So light sometimes doesn't penetrate that deep, but focused ultrasound can. So we're going to use it to activate the 5-ALA to produce the free radicals and kill the tumor. So this is a preclinical study, and let me show you. Here was the tumor growing inside the animal model from day 10 to day 23, where it's at its maximum size. This is the control group. If you give just the 5-ALA, the tumor is not really changed in size. The 5-ALA doesn't do anything on its own. Focused ultrasound alone with these parameters doesn't really do much either. But with the sonodynamic therapy, if you give the 5-ALA plus the focused ultrasound, look at how much smaller the tumor is. It decreases the rate of growth, which is shown here, and as well, the tumor suppression rate is shown here with the sonodynamic therapy, the 5-ALA plus the focused ultrasound versus just the focused ultrasound alone. So there have been many other preclinical reports that have also confirmed this finding, also shown here in the graphs with the improved survival when you do the 5-ALA plus the focused ultrasound. And in fact, we now have 2 clinical trials going on. One has already started recruiting and one is about to start recruiting. So we're very excited to see these results in humans. How about radiation sensitization? In this article published by this group here, the Emerging Applications Beyond Tumor Ablation, you can see, again, I've taken you through these multiple mechanisms of action of how focused ultrasound can work. We've talked about the immunomodulation going from cold to a hot tumor. We've talked about drug delivery and blood-brain barrier opening. We talked about sonodynamic therapy, but this is now radiation sensitization. So again, there have been multiple preclinical studies that have shown the ability of focused ultrasound to enhance radiation therapy effects with mild hyperthermia. And in this study, what they found was that the combination of ultrasound with radiation therapy resulted in more cell death than either therapy alone. And in these pictures here, we have the control tumor with just focused ultrasound with the microbubbles, the radiation therapy and the combination, we see less flow when using the combined therapy and less oxygen in the tumor when you were using the combination of focused ultrasound and the radiation therapy. So it's very exciting work, and we're having some clinical studies that have already started and other ones that are about to study to explore this. So I've taken you through a bunch of these: blood-brain barrier opening with drug delivery, sonodynamic therapy. We did some thermal ablation with other etiologies that are currently in use, hyperthermia. But let's take all of them together. What can all of these things do? Well, this is a really exciting area, and it's called liquid biopsy. So perhaps you guys have heard that for other tumors like colon cancer, lung cancer, that you can take a peripheral blood sample and look at certain tumor markers in it to see if the patient has a cancer and perhaps some of the genetic changes that are in it. But if you look all the way over here to the right, do you see this says glioma down here? The glioma patients don't have a lot of circulating tumor DNA in the peripheral blood. All these other tumors, bladder, colon, hepatocellular, breast, they've got a lot of tumor markers in the peripheral blood. But I bet you guys know the answer now why gliomas don't have a lot of DNA in the peripheral blood. And it's because of the blood-brain barrier. Things can't get into the brain and things can't get out of the brain. So let's get back to this picture for a second, where we know there's marked heterogeneity in a glioblastoma. So the question is, if we want to get, let's say we certain drugs into this area of the tumor, we can. If we open the blood-brain barrier in these non-enhancing regions, we can also get the cells from there and the DNA from there to go back into the peripheral blood. So we can do a targeted, non-invasive liquid biopsy before focused ultrasound and then right after focused ultrasound to see what changes in the DNA are in the blood after we open the blood-brain barrier in those regions. So this is really cool. There are numerous articles now showing that targeted therapies for glioblastoma are important. We need to know what genetic and epigenetic changes are in different areas of that tumor to successfully treat it. So as you can see here, there's non-enhancing tumor in red and green, enhancing tumors in more magenta and blue. So just think about using focused ultrasound to open the blood-brain barrier in all these areas to see what's hiding in there. What actionable mutations are in there? So again, we can use focused ultrasound to open the tight junctions and get medicines into the tumor. And we can also use it, to get that tumor to secrete its DNA, RNA, and proteins back into the blood to examine it. So these are courtesy of Dr. Hong Chen. She's doing tremendous work in this area. And it started with mice. And she looked at focused ultrasound-enabled brain tumor liquid biopsies and showed there was a tremendous increase in the amount of GFP after you did focused ultrasound opening of the blood-brain barrier compared to control. So she successfully opened it, got stuff to go from the brain into the peripheral blood. Then she moved on to porcine preclinical studies. And again, showed that in brain, she was able to release more GFAP and myelin basic protein, just substances in the brain, into the peripheral circulation compared to without focused ultrasound. Cool, okay, so far so good. Then she moved on to do focused ultrasound and showed that it was safe and effective to release brain tumor markers into the peripheral circulation. And remember we talked about that dimmer switch that you can use like higher energies to open it more and lower energies to open it less. And she looked at different pressures of using the ultrasound beam and again showed there was the ability to release more markers into the peripheral circulation with increasing pressures, but the safest level was actually the gray area here. But it was a really important study. And we're doing this in patients now, where we're doing focused ultrasound enhanced liquid biopsies to see if we can, in humans and in patients with brain tumors, increase the amount of circulating DNA from the tumor before and after blood-brain barrier opening. And you can see here the tremendous increase in the amount of cfDNA post-BBB opening compared to before. And this is from this study. These are the 9 patients that were reported in the study. Again, you can see here the area in red and outlined in blue, the areas where they opened the blood-brain barrier. So this is very exciting work. And there's another study going on with Dr. Sonodynamic at Northwestern to explore this as well. So for focused ultrasound liquid biopsies, you can improve the quantity and quality of liquid biopsy markers. Let's see if we can see those genetic and epigenetic changes. We can non-invasively maybe diagnose GBMs and other brain tumors. We can guide targeted therapies for personalized care. We can provide longitudinal follow-up. There are certain markers that show us that perhaps the patient's tumor is progressing versus pseudoprogression. We can provide real-time feedback to add or remove therapy as the tumor evolves. We know that these tumors mutate and change all the time. So if we can constantly get a non-invasive biopsy to show what's changing in the tumor and direct treatments against it, that would be huge. In this picture, that's me, my husband, and our very good friends. And I want to do a big shout out to Zoraida, and I'm so proud of her because she's been battling glioblastoma for 2 years now, and she still parties on. So kudos to her. And for the future, I want to tell you about 2 other exciting things with focused ultrasound. One is called Oncotrypsy. So it's a way to adjust the focused ultrasound beam so it selectively kills cancer cells, let's say, which is shown here in red, versus healthy cells, which is shown here in blue. And it takes advantage of the fact that the cancer cells have a different phenotypic makeup, like their cell membrane may be thicker. So if they can adjust the beam to just kill the cancer cells and not the healthy cells, that would be huge. So here we have a little video of the beam going and just killing the cancer cell and leaving the healthy cells alone. So that would be really cool. And then there's this work out of Caltech, which is doing acoustic remote control of bacterial immunotherapy. So it turns out that certain bacteria will accumulate in tumors, like glioblastomas, and they can follow this bacteria. There's certain properties of it that allow us to follow it like a tagging agent, and it can deliver payloads like checkpoint inhibitors. So as you can see here, the therapeutic microbes, the bacteria with focused ultrasound, resulted in maintenance and decreased growth of the tumor volumes compared to the focused ultrasound or the microbes alone. So that's very, very exciting work. So hopefully I've taken you through a summary of how focused ultrasound is being used in neuro-oncology. The current status is still these 4 pillars of cancer, but I've shown you how different modes of focused ultrasound, both thermal and mechanical, can either improve on or provide an alternative to these 4 pillars. And hopefully I've also shown you that this column of immunotherapy is really being investigated with focused ultrasound and really has the potential to affect this cancer immunity cycle in so many ways. So thank you for your time and attention, and I'm welcoming any questions.
Oh, thank you so much. That was very informative. I love your enthusiasm for this. You could tell that you're very interested. That was excellent. You answered most of the questions already. There's a few more. First is, can brain tumor patients use this right now? It's approved for other things, so can you use it off label?
So we don't want to use it off label yet, but there are many clinical trials going on with the blood-brain barrier opening, the sonodynamic therapy. So if you go onto our website, busfoundation.org, there's a drop-down menu for clinical trials, and you can sort it out by your disease process and find clinical trials. And if you have any problem, you can, of course, email me at sleblang@fussfoundation.org. So we help get patients to the proper clinical trials. So, yeah.
Okay, how many hospitals have this equipment right now?
So there are at least, I would say 40 in the US and over 100 worldwide of the different machines that can do different things. So again, all of that information is on our website. Some places are not doing, or they're just doing like essential tremor and tremor dominant Parkinson's disease and not blood-brain barrier opening. Some places are doing blood-brain barrier opening and not sonodynamic therapy. So there are a lot of places, but not every place is doing all of the different applications.
Okay, from the FDA's point of view, do you get the device and the procedure approved and then you can use it with any drug, or do you have to get every drug combination approved separately?
That's a great, great question. And it's very fortunate that we have a really good relationship with the FDA and we keep them involved in all of our workshops. Let me see if I think I have one more slide. Let me see. Oh, can I show this? Can I just
Sure.
a little bit more. So what the Focused Ultrasound Foundation does, and this will help answer your question, is that we have workshops. So we have blood-brain barrier opening workshops every few years. GBM workshops we had in 2015, and we're going to have another one this coming week, which I feel free to,
You can promote it. Go ahead. You can tell people.
Can attend, absolutely. Now that it's virtual, anyone can come. Our executive committee, as you can see here, is made up of really leaders in the field of neurosurgeons and neuro-oncologists. And so we have a great agenda set up, but we also invite the FDA. And we have all of the people from the device portion as well as the drug portions coming. And the device drug combination is important. And it's hard to get past through FDA, but we're working very hard because the FDA is now much more comfortable with the devices for blood-brain barrier opening now that hundreds of patients have been treated in clinical studies.
Right.
And in some cases for using an existing drug, they're comfortable with that, but we still have to get them approved together. So a little cumbersome, but we have a great relationship with the FDA and they're understanding and the technology more and more. We also work with other nonprofits to, let's say, help us review studies. We want their expertise. We also work with them for co-funding opportunities and for educational experiences like this. We work very closely with numerous societies. I just listed a few here and various manufacturers. And again, this is what the FUS Foundation is doing. We're trying to get something that's a standard of care and bring it up 10 years and really help expedite the research and working to get it to commercial status so we can help patients.
Okay, let me ask you a question about Parkinson's because you mentioned it. That was a very amazing slide that you showed. How long does that last? Is that permanent?
So for essential tremor and tremor-dominant Parkinson's disease, we have, I think, like 2 to 4 year data out right now that it is durable. Some patients, they need bilateral treatment. So we're doing staged bilateral treatments to help them. But it is durable and it is safe. And again, it's FDA approved for essential tremor and tremor-dominant Parkinson's disease. There's some other components of Parkinson's disease like dyskinesias that are going through FDA approval right now.
What percentage of Parkinson's patients would have an improvement like that?
For the tremor dominant symptoms, a lot. It's actually the same tract as patients who have essential tremor. So we have a lot of experience with that. But what's incredible, and if you remember that slide I showed you, is we're literally hitting a tract that's like 3 millimeters. And if you go 2 millimeters off target, you can get side effects. So it just shows you the amount of precision that this machine can do. It is super precise. And the fact that you can provide imaging guidance to see your target and monitor it with the thermal therapy makes it very safe and efficacious.
Okay.
What's amazing is that we're using that thermal ablation technique for lots of other diseases in the brain. And again, you can look it up on the FUS Foundation, but chronic neuropathic pain, psychiatric disorders, there's lots of other.
It's funny, I was just going to ask you, is there any use for ALS?
Interesting that you say that. I'm glad you brought it up. So we've shown that we can open up the blood-brain barrier safely in other disease processes. ALS is one of them. And now we're looking to open the blood-brain barrier in the area of the brain where ALS, is defective and administer a therapeutic right there. Wow. So we're going into clinical trials with that, but opening the blood-brain barrier safe, perhaps one of the most exciting areas, again, that we've done the blood-brain barrier opening with is with Alzheimer's disease.
Oh.
And what we've shown, just to bring the whole thing full circle, is that we can open the blood-brain barrier in multiple areas of the brain that are affected by Alzheimer's disease, either with imaging studies that we know the amyloid or the tau is deposited, we can target those areas. Focused ultrasound alone has been shown in preclinical models and some clinical studies now that it opens the blood-brain barrier and lets our immune system cells in to clean up the amyloid and the tau. So focused ultrasound alone can show some improvement, but we're also looking to open the blood-brain barrier and administer therapeutics now, right? So again, wow. Opening that blood-brain barrier for a multitude of diseases is going to be really important.
Another question, the same question I asked before, but the problem with using it off-label, is that the FDA saying no, or is that you guys, like the manufacturer saying no?
Right. So the Focused Ultrasound Foundation, works completely independent. We're agnostic to respect to the manufacturers, but I think the manufacturers, really want to do this safely and carefully. So I am not aware that anyone's done it off-label. But again, we're a foundation, so I'm not.
Yeah, we just have no patience. We see something we like, we want to get it,
Get in clinical trials. Yeah.
Sure, that's always the best way. But when you can't get into the clinical trial, or if you have an idea for something different, it's tough.
Yeah.
Let me see. Can you do this repetitively? Like, say you're getting Avastin once every 2 weeks. Can you do this every 2
Yes.
weeks?
That's part of the clinical trials that are going on now. And in fact, that one paper published the results of 6 patients who had 145 episodes of blood-brain barrier
Okay,
opening.
okay.
So do the math, right? They received multiple sessions over time, and it was safe and right.
Okay, and can you do multiple mechanisms of action at the same time? Like you open up the blood-brain barrier, and then first of all, you get the liquid biopsy. Then you could also do a little hypothermia or some of these other things. Or can you only do one thing at a time?
Al, you're ahead of your time. That's exactly why I'm so excited, because what I envision is that liquid biopsy will show us which area needs radiation sensitization, which area needs sonodynamic therapy, which one has a targetable agent for a certain chemotherapy or immunotherapeutic drug. So I think it's going to be the combination of everything. Yeah.
Okay. So you open up the blood-brain barrier, give a drug, then you said it closes within 24 hours?
Yep.
Does it then trap that drug inside so it should stay in there longer?
We hope so. We think so. It's hard
Okay.
to tag a lot of the agents because it's quite expensive. We're really trying to, because we really want to follow the drugs. We don't want to put catheters in there because the whole point of this is that it's non-invasive, right? So different preclinical studies are still investigating it, but we hope to show with the clinical outcomes that the drug is likely staying in there.
Somebody asked about 5-ALA. That's glialin and that's approved, so it's readily available.
Yeah.
I just wanted to mention that.
And yep, go ahead.
You mentioned you showed on the slide histotripsy, but I don't think you mentioned it. What is that?
Right. So histotripsy is a mechanical way that we can use the focused ultrasound beam to kill tumor cells. And I have a whole nother lecture that I could give on that. But basically, if you kill cells with thermal ablation, it dies by coagulative necrosis. Okay, so the cell kind of stays intact, but the cellular organelles stop working because they can't work in that heat environment. If you kill a cell with histotripsy, it's a mechanical destruction of the cells. So when we talk about releasing some of those antigens to then start the cancer immunity cycle, we're trying to decipher which mechanism of action will release the most antigens intact, right? So because those will help elicit the most innate immune response. So histotripsy is currently being used in trials for liver tumors. So we're hoping to get it into brain because we think it will help us reach certain targets that we can't right now with other mechanisms of action of focused ultrasound. And obviously the skull is also an issue that we haven't even talked about today, but there have been tremendous technical challenges to get this focused ultrasound beam in the brain, but we can do it with all the things I talked to you about today. But histotripsy is really promising. So we're very excited to continue exploring research in that area to hopefully get it into brain tumors.
Okay, this is a specific question. Somebody has a thalamic glioblastoma. It's not a candidate for resection, and the standard treatments are not working. Which of your clinical trials do you think might be eligible for this type of case?
Yeah, I'm happy to direct that person to some of the blood-brain barrier opening trials. The sonodynamic therapy trial, I believe right now is a treat and resect. So if it's in the thalamus, it would not be able to undergo that clinical trial right now, but I would have to double check, but I'm happy to help that person find which trials are available for them.
Okay, there's a bunch of questions. That's basically the same answer.
Okay.
Let me see, what else? Did I miss anything? That's about it. I think that answered all of our questions. I want to thank you so much for taking time on Mother's Day. Happy Mother's Day.
Yeah, thank
Um,
you.
our next webinar is going to be next Sunday night, 7 p.m. We actually have 2 topics next week because we just had to fit them all into Brain Tumor Awareness Month. The first is perfusion MRIs of the brain tumors. And that's just a better way of saying where the tumor is and how the tumor is responding to treatments. And then there's a phase 1 study of a new drug candidate for high-grade brain tumors, and it's going to be sort of a surprise because it's never been announced before. So we're going to be talking about a new candidate for brain tumors. That's all next week. So I'll see you guys next week. And
Thanks,
thank you
everyone,
so
and feel
much.
free to sign up for the GBM workshop. We hope to see you there. There's going to be lots of
Oh,
super
just tell
interesting.
them what's the web address?
Well, if you go on the fussfoundation.org, you can find links to the GBM workshop. And Al, if you could send it out in your emails too.
Okay, it's free, right?
Yeah, totally.
And patients are welcome, right?
Yes, anybody.
Perfect. Okay, thank you and good night.
All right. Good night, everyone.